And okay, let me go to the next speaker. Professor Miklos Kertai from Vanderbilt University Medical Center, who will be speaking about the role of disparities in Alzheimer's disease, the role of predictive disorders, and surgical exposures. Dr. Kertai, go ahead.
Thank you so much. Can you see my screen and hear me?
Yes, we do.
Yes, we do.
Perfect. Thank you very much. Good morning, everyone, and thanks again for the organizers to inviting me. There's also, I'd like to point out that this work has been done in collaboration with Dr. Akushevich, Yashkin, and Kravchenko, and it has been a very interesting and fruitful collaboration to look into the role of disparities in Alzheimer's disease in terms of the role of anesthesia and surgical exposures. I'm a cardiothoracic anesthesiologist at Vanderbilt University Medical Center, and previously I spent 7 years at Duke as a cardiothoracic anesthesiology. So this is basically the origin of our collaboration between Duke and Vanderbilt. I have no disclosures regarding the content of this presentation. And in my presentation, basically, I will divide up the talk into two sections. The first one is will be dedicated to reviewing the prior literature in terms of what prompted us to look into this potential association between anesthesia/surgical exposure and the risk of Alzheimer's disease in patients undergoing surgery. And in the second half, I would plan to actually share our study findings in terms of what we have found using the SEER Medicare data set in patients who underwent colorectal cancer surgery. So we all know that patients who are elderly are at a substantial risk for developing Alzheimer's disease. This is important to realize because this is exactly the segment of the population that is highly likely will be exposed to repeated surgical and anesthesia exposures for their pre-existing conditions, or because they are actually much higher for developing cancer disease, which down the road will eventually require surgical intervention with anesthesia exposure. So clearly this actually forms an ideal population to study in terms of the exposure of anesthesia and surgery and the risk of Alzheimer's disease. It is also an ideal population to study whether there are any disparities in terms of how patients undergoing surgery and exposure or exposed to anesthesia will potentially respond differently and therefore identify a subset of the patient population who could be at much higher risk for developing Alzheimer's disease. So we all know from prior epidemiological studies that African Americans and Caribbean Hispanic Americans tend to have a much higher incidence for Alzheimer's disease and dementia than other races in the population. We also know that some of the chronic comorbid conditions are also more prevalent in African Americans and Hispanics. We all know that cardiovascular disease and diabetes are much more prevalent in African Americans and Hispanics. We also know that education level, poverty, and exposure to adversity are also prevalent in African American and Hispanic communities. And from prior literature, we are aware that when studies tried pinpointing and identifying genetic factors that could actually drive the risk for Alzheimer's disease, the results were actually mixed in terms of some studies findings a positive association, whereas others actually found no association between certain genetic markers and the risk for Alzheimer's disease. So how about some of the disparities related to or specific to gender? We all know that there are some specific differences between men and women, and these differences in physiology could actually drive the high risk of Alzheimer's disease and dementia in elderly women compared to men. So we all know that studies in the 90s and the 2000s, there has been a significant attention actually devoted trying to reduce the risk of cardiovascular conditions and mortality in men, but not in women. So clearly their cardiovascular disease burden is much higher compared to man. Also, there are some sex differences in inflammatory response reaction to ischemic injury of the brain and other organs. There's also the factor of lower educational attainment in women compared in men. And in some basically other studies, it was found that there is a potential interaction between ApoE genotype and the estrogen level and the vulnerability of the brain to different stimuli, such as or including surgical stimuli that could actually increase the risk for the development of Alzheimer's disease and dementia. And there is an extra added layer to the complexity of trying to actually dissect and understand a potential association between anesthesia exposure, potential disparities on a racial or on a gender basis, and the risk of Alzheimer's disease. We all know that cancer and having a cancer disease has shown an inverse association between cancer and the risk of Alzheimer's disease and dementia. We don't particularly know why there is such an inverse association. Obviously, there are multiple different lab-based studies that indicated a potential pathophysiological mechanism that actually provides some protection against Alzheimer's disease and dementia in cancer patients. But in humans, these studies have not really prevailed consistently to establish such a link between cancer and Alzheimer's disease. This is a rather busy slide, but what it actually trying to indicate when the potential and very intricate association between cancer, exposure to chemotherapy, and the risk of cognitive impairment and the risk of dementia in the long term. But obviously, what is often missing from these studies, whether these are lab-based studies or population-based studies, that given the higher incidence of Alzheimer's disease in elderly population and their risk of developing chronic diseases requiring a surgical exposure with anesthesia often is actually not considered as a potential driving factor or a modulating factor in terms of cognitive impairment or the risk of dementia in the long term. So how about the anesthesia literature? So this was a review article published back in 2016 and trying to look into basically the available evidence that would actually point to one or the other direction in terms of whether there is an association between anesthesia exposure to surgical procedures and a subsequent risk for developing postoperative cognitive dysfunction, long-term cognitive dysfunction, and the risk of dementia. And as you can tell, there have been very few or no studies that were actually well controlled and provided substantial and good evidence for establishing such a link. So how about looking into some other studies that were actually trying to sort of dissect the potential or identify a potential association between exposure to general anesthesia and the risk of Alzheimer's disease? These studies actually were driven on the premise that in animal studies, what was observed that exposure to volatile anesthetics could potentially inflict inflammatory response reaction in the brain, and subsequently changes similar to changes what occur in Alzheimer's disease will occur in the brains of animals exposed to such volatile anesthetics, and therefore increase the risk for Alzheimer's disease. Obviously, as you can see in the forest plot, clinical studies or longitudinal studies looking into the exposure to general anesthesia and the risk of Alzheimer's disease were not able to actually consistently establish such an association. This is yet another busy slide in terms of trying to come up with a potential pathomechanisms by which exposure to anesthesia could actually inflict certain changes in the human brain and through neuroinflammation and subsequent neurodegeneration increase the risk for cognitive impairment and a long-term risk for Alzheimer's disease and Alzheimer's disease-related dementia. So in order to address some of the shortcomings of the previous studies, and obviously those shortcomings were related to the fact that often clinical studies trying to basically look into the association between exposure to general anesthesia and Alzheimer's disease or related dementias risk, we actually did not have a sufficient follow-up time to follow through those patients in terms of their risk of developing Alzheimer's disease, or were not actually had enough number of observations to adjust for multiple and highly relevant risk factors in terms of trying to understand whether there is a risk between exposure to anesthesia and whether such a risk is actually differential in men and women or in ethnic minorities. So in order to address some of these previous shortcomings of studies, we embarked on conducting a retrospective study using the SEER Medicare data of patients who were diagnosed with colorectal cancer between 1994 and 2009. And the reason why we actually decided to work with patients who were diagnosed with colorectal cancer, because their care resulted in a substantial survival gain over the last 20 years. And therefore, there is sufficient time to study these patients in terms of their risk for developing Alzheimer's disease or Alzheimer's disease related dementia. We can also basically, we could also adjust for anesthesia exposure, in particular because colorectal cancer patients likely tend to undergo repeated surgical procedures with repeated exposure to anesthesia, and therefore the cumulative exposure to anesthesia could be studied as a potential driving factor of the risk of dementia in colorectal cancer patients. So again, just a quick recap how we started with a larger cohort of patients and subsequently applying certain exclusion criteria, mostly because some pertinent and important information was lacking in terms of exposure to anesthesia and duration of such an exposure. Our final sample size was well over 84,000 subjects available for this retrospective study. So in terms of what were the different procedures to which these patients were exposed, so as you can tell, most frequently these patients were exposed to repeated surgical and anesthesia exposure for abdominal and pelvic procedures. So these are exactly the procedures that are performed for patients with colorectal cancers. It's not just a single surgical exposure in time, but often these patients will have to come back for repeated procedures, either for staging purposes or for other follow-up cancer surgical procedures, and therefore they are going to be exposed to repeatedly to anesthesia as well as to surgery. So this is a rather busy forest plot, but what is basically it's telling us is trying to study the hazard ratios of selected predictors of those 47 predictors we considered in our study that were previously identified as potential predictors for Alzheimer's disease in our study population. And as you can tell, certain and specific surgical procedures and anesthesia for these procedures and certain comorbid conditions were either associated with a higher hazard of Alzheimer's disease or with a lower hazard, or had no differential effect on the risk. So going further in our adjusted analysis, we found something particularly interesting. And what we found actually, as you can tell in this figure, that there was no association between exposure to anesthesia for colorectal surgery and a higher hazard for Alzheimer's disease. In contrast, what we found actually that there was an association between a higher hazard for Alzheimer's disease and related dementia in patients exposed to anesthesia, as well as cerebral degeneration, encephalopathy, and hepatic encephalopathy. And most importantly, there is an association, a higher association or a higher risk for a higher hazard for delirium. Particularly important because a significant proportion of patients undergoing major surgeries, such as colorectal surgery, could be at much higher risk for developing postoperative delirium. So particularly in our study, what we could do, we were able to look into a shortened delirium that was happening immediately after surgery and incident delirium that actually happened during the follow-up period. And what we were able to find that both incident delirium as well as postoperative delirium were associated with a higher risk for Alzheimer's disease. So we kind of explored an interesting sort of association here, meaning that exposure, there was no direct association between exposure to anesthesia and the risk of Alzheimer's disease, but it was associated with a higher risk for postoperative delirium, which then was associated with a significantly higher risk for Alzheimer's disease in the long term. This is just basically a visit table with the summary of our association analysis, similar to what was displayed in the graph previously shown to you. And then going further and trying to actually study whether there were any disparities or a differential effect of exposure to anesthesia in African Americans compared to whites. We also basically replotted our associations using a forest plot, and we could not actually confirm that race was a significant or played a significant differential effect in terms of having an association between exposure to anesthesia and the risk of Alzheimer's disease. How about adjusting or considering gender? Again, we could not actually found that there was a differential effect in terms of the risk between exposure to anesthesia and Alzheimer's disease in men and women compared to when it was studied in the entire patient population. So in terms of discussing some of the methodological aspects of our study, clearly this is a retrospective database or registry-driven study, and therefore we had to actually apply certain sensitivity analysis just to make sure that the lack of observed association between exposure to anesthesia or the lack of association between the differential effect of gender and race on the risk of Alzheimer's disease in patients exposed to anesthesia for colorectal surgery were actually held true in our statistical analysis. Furthermore, clearly given the nature of the variable exposure to anesthesia, we could not study bioavailable methods because the main predictor was actually continuous and time dependent. And obviously, we had to consider death events that were censored as dependent censoring as part of our statistical analysis. So to summarize my presentation, our study could not actually find sufficient association or evidence to confirm that there was an association between exposure to anesthesia for major surgeries such as colorectal surgery and the risk of Alzheimer's disease. But most importantly, what we could actually found and somewhat confirmed in relation to the findings of previous studies, that exposure to anesthesia was associated with a higher risk of postoperative and incident delirium, and postoperative and incident delirium were associated with a much higher risk for Alzheimer's disease in the long term in this patient population. Thank you for your attention, and thank you again for inviting me to participate in this very important symposium.
Okay, thank you, Dr. Kertai, for a very interesting and informative talk. And I see we have a raised hand. Or Igor, did you just want to ask something? We just forgot to lower your hand. From the last
No. I just Miklos, you demonstrated the study of colorectal cancer, anesthesia, and the risk of dementia-related conditions. So when we make similar studies, it's very difficult to distinguish between the effect of anesthesia, pure disease effect, and maybe effect of surgery. is there a consensus between anesthesiologists about this, about the effect of pure anesthesia, and can you predict what will happen if you consider different diseases?
So this is, you know, a kind of a catch-22 questions, obviously, because nobody will be exposed to sham anesthesia or sham surgery with anesthesia rather. And therefore, you know, the individual effect of anesthesia would be very difficult to study. So there's always this lingering question in the background. Is it really surgery driving the risk and anesthesia has nothing to do with the risk? Or actually the combination of the two may have an additive effect in patients potentially vulnerable to both exposures, meaning surgical and anesthesia exposures. And clearly, you know, this is considering some of the animal and laboratory-based studies, there's an indication that certain anesthetic medications could actually result in some inflammatory changes in the human brain. And therefore, especially in those patients who, for whatever reason, either genetic or for other reasons, have a higher risk for being more vulnerable, could actually drive potentially a higher risk. On top of that, you're always going to have basically surgery as a potential driving factor. And in terms of having or not having a consensus in our community, we know that certain medications we use in anesthesia or in the postoperative setting in the ICU could potentially increase the risk for postoperative delirium without really even having surgery. So you can consider, for instance, patients who are getting actually admitted to the medical ICU without actually a prior surgical intervention. And we know that our medications, some of our medications could potentially increase the risk for delirium. And as we actually found in our study, maybe this is a potential link kind of in terms of exposure to anesthetic medications, the risk or higher risk of delirium, and then subsequently a higher long-term risk for dementia, such as Alzheimer's disease. But there is no straight answer here to give, Igor. So it's a kind of a difficult topic to study. And I think we've done a great job in terms of trying to sort of dissect and understand this association. Yet there is still kind of a disagreement within the anesthesia as well as the surgical community in terms of what is the real driver of the risk for Alzheimer's disease or dementia in patients undergoing surgery.
So let me understand. So the consensus is, if the effect exists, then the mechanism is through delirium as a mediator. Is it correct?
I think this is what we have started actually seeing, you know, especially, you know, referring to the first presentation too, a significant number of patients actually with, for instance, with COVID, that, you know, kind of let me backpedal a little bit and say that typically the rate of postoperative delirium can go anywhere between 20 to 40% of patients admitted to the ICU. With this ongoing COVID pandemic, the rate is now up to 80%. So clearly, you know, there is something going on that drives postoperative delirium, then subsequently being in postoperative delirium drives and make changes in the brain that are inflammatory response reaction to either to the COVID itself or surgery itself or anesthetic medications. And subsequently, this is the potential kind of risk that drives the risk for Alzheimer's disease. So there's an ever-growing consensus that postoperative delirium and whatever leads to postoperative delirium is likely a significant driver of the risk for dementia in a subset of patients who are vulnerable to surgery, anesthesia, or anything that happens in the ICU once they admitted to the ICU.
Okay, thank you.
Okay, thank you. And we have a question from the audience in the Q&A. So did you examine the correlates of race?
Race with Alzheimer's disease?
Oh, well, I don't know. It's like correlates. I mean, I believe correlates of race with your outcome, which you analyze it. Maybe Peggy will clarify more the question.
That's all right. So we studied the potential association between, gender and the different outcomes we had in our study, as well as the race and different outcomes in our study. And we could not actually confirm that, race or gender were kind of had a differential impact on the risk.
Yes, and we have this clarifying from Peggy, correlates of race with your outcomes. Yes, that was one correct guess.
Yep.
Okay, thank you.
Okay, Konstantin, I have a question. I tried to raise my hand, but I think Galina keeps my video closed. So, Miklos, very nice talk. Thank you. And my question deals with, you have a nice table about hazard ratios for different risk factors. Did you try to look at, to make some multivariate analysis of this, including many risk factors simultaneously in the analysis, or maybe even looking at interaction among these risk factors?
So obviously, given the time and limitation in terms of how detailed you can be during such a presentation, that information hasn't been presented here. But Igor can also attest to that. We particularly went into detail in terms of adjusting for the different comorbid conditions that could increase the risk for Alzheimer's disease-related dementias, and some of these chronic neurocognitive disorders. We looked into running different sensitivity analysis. So we went really sort of above and beyond in terms of trying to turn this upside down in terms of making sure that the observed associations or a lack of it can be well explained with the data available to us.
Thank you. Could you also tell us whether there are some genetic influence on the effect of anesthesia on neurodegeneration?
Yeah, absolutely. This is a very valid point you raised, and all sort of fingers point to the direction of having a genetic variation in APOE. Our previous study with some Duke collaborators indicated that having a genetic mutation in APOE increases the risk for postoperative delirium. So when I was referring earlier to having a vulnerable brain, it's likely that these patients with such a genetic variation or a set of genetic variations in other genes could be at much higher risk for the detrimental or harmful effect of anesthetic exposure, as well as the inflammatory response reaction that follows surgery. And subsequently, these patients will be at much higher risk for postoperative delirium, which will then drive the long-term risk for Alzheimer's disease.
Thank you.
Okay, thank you. Any other questions from anyone?
Yeah, I have a question. Very nice talk. When you showed figure for association with delirium during 1, 2, up to probably 15 years, I noticed that there was like increase in probably confidence intervals over time, right? What's the reason? Is this because of death, loss of people who lost to follow-up, or maybe some sort of heterogeneity?
So I think this is something that Igor could potentially address, because this is a relevant question you asked. Igor, would you like to chime in?
Excuse me, let me interrupt you because, okay, we are running out of time. We have 30 minutes for discussion. Alexander, we'll postpone your question.
Okay.
Maybe we can discuss this on our discussion section after this
Yes,
session.
that's what I'm talking about. Sure.
Thank you.
Thank you, Dr. Kertai, for a very interesting and informative talk.